and then see this one also. Now how you should actually insert an implant. An implant actually comes in a sterilized bottle where it is actually mounted on a mount. So you have to just take the abutment into the implant holder here, and then you have to just break it so that the implant will actually come. The abutment is inside and the threading surface is outside. Now before you actually insert it into the osteotomy site, before you even insert it into the osteotomy site, you have to always support the implant at the level of the shaft, not on the thread surface. If you see in the image there, the shaft is there, the thread is there. Don't put your fingers on the thread surface, rather put it on the shaft, support it. And wherever you want to insert it, insert the implant. Insert the implant, make sure it is stable, then remove it. And then, now whenever you are rotating, make sure that the head of the implant or driver or the holder, your palm is actually resting on that, and you are actually rotating only with the fingers. You are rotating only with the fingers. Okay? You should rotate only with the finger. Don't do it like this. If you do it like this, what will happen? You are actually breaching a lot of bone there. Right? So it's the same thing what happened in the drill. R1. First you will get resistance. Second you will get D1, dip 1. Means your implant will actually be going very freely. First you will get resistance, but this is where you have to be little careful. Because whenever there is a D1, till the time you reach the second osteotomy site, which is the part that is there actually in the cortical bone, that is in the R2 region, there is a chance that if you are using your elbow movements like this, there is a chance that you will be changing the implant direction. It might either go in the buccal or in the palatal direction, right, which is very undesirable. The implant will never go and sit in a proper position. So for that reason, you stabilize the implant first and then just do only a finger rotation like this. What I am showing you, just do it only in a finger direction so that there won't be any changes in the implant direction. Once it engages into the second osteotomy site, that is the R2 region, you will start getting resistance there. That is where you can use little bit, not too much of a force, gentle push with your palm. Gentle push, just gentle push, rotate, gentle push, rotate, gentle push, rotate, gentle push, and then rotate. And when you are placing an implant, now if you see in the diagram here, make it that this is a conventional and this is the bi-cortical implant. Make sure that your abutment is slightly subcrystal. Make sure that your abutment is slightly subcrystal. I told you an abutment height of 4 mm is more than enough for you to place a crown over it. Right? So in extraction sockets also, try to place it subgingivally. Try to place it subgingivally. Don't place it supragingival or supracrystal. As far as possible, try to place it subgingivally and subcrystally, so that there you will not be, because sometimes what will happen if the height is more, you need to trim the abutment. To the maximum extent, try to avoid trimming. To the maximum extent, try to avoid trimming of the abutments, because even that slight micro movements can also sometimes lead to, derotation of the implant. So to avoid all these things, right, it is always better to place the implant in a proper position, whether to place it in a subcrystal or a subgingival position. Is that clear, guys? Okay. Now, so this is the OPG of implants that were placed. You can see on either side 2 pterygoid implants are placed, and then in the 7 regions, and in the canine regions the implants are, which I told you that you should not avoid. They are actually placed in the right position there. Now somebody was asking me the posterior wall of the sinus. See, in the OPG, this between this and this area, this entire area, this entire zone is nothing but is your posterior wall of the sinus. You can actually place 2 implants in that. Okay. Now if you see it on the opposite side also, This entire area between these two cortices is your posterior wall of the sinus. So, if you want to put an implant, you can actually place an implant here also like this. If you're not able to, don't be in a hell-bent upon situation where you have to place a pterygoid implant just because I have learnt it, let me place. Sometimes you will not get that amount of torque, but in posterior wall of the sinus most of the time you will get a very very good torque. Because in pterygoid region you might get a very good torque, but sometimes for you to get it in a desirable direction you might attempt to bend it. That bending also sometimes will cause loosening of the implant. So, if you have a good posterior wall of the sinus in the OPG, this is how you can actually make it out. The lines that I have drawn there. If you have that much amount of space, don't hesitate. Nicely, you can put 2 implants minimum there. Clear? So next, moving on. So sin crystallization. Sin crystallization is nothing but a scientific term that is given for welding. Now, what does we do? What do we generally do in welding? Is that you take a thin 1.5 mm diameter wire, titanium wire, you adapt it to the implant abutments, and then you intraorally you weld them together. Now, once you weld all the abutments with one piece of a wire, all of them will become one unit. Now, 1 mm wire, you can actually do it intraorally itself. You can do the wire adaptation nicely, intraorally itself you can do. But if you are using a 1.5 mm wire, it is quite difficult actually to adapt it intraorally. In such cases, what you have to do, take an impression, pour the cast, over the cast, you have to actually adapt the 1.5 mm wire, and then it will be nicely seating intraorally, and then weld it. Now, what is the advantages of this sin crystallization is that it will prevent a lot of micro movements. Let us say, for example, if at all, I am not saying this is you should do this, if at all you get a slight, slightly mobile, one of the implant is slightly mobile. See, grade 1 mobility kind is allowed, but grade 3 is never allowed. You know what is grade 3 mobility of a tooth, right? Means there is a depression into the socket also. Right? There is a vertical movement. That is not allowed. If that is the case, please remove that implant and then put it in again one more desired position. Don't think that anyways I am going to weld it, it will be successful. It will not be successful. It will create a lot of headache for you later on. If it is only grade 1 mobility, slight mobility in a lateral direction, not in the vertical direction, then what will happen when you are actually welding it together? When you are actually welding with the titanium wire all the abutments together, even that also will get stabilized. The one that is slightly more. That is one advantage. Apart from that, even let us assume that all are having a very good torque. All the 20 implants that we place for a full mouth are all having good torque. So what will happen is, small micro movements might happen when you are actually trying to bend an abutment, right? Or when you are actually trying to trim. So it is always advisable that whenever you are actually trimming an abutment, do it in a clockwise direction only. Don't do it in an anti-clockwise direction. Do it in a clockwise direction, in the direction in which you actually tighten the implant. So trimming also should be done in a clockwise direction. Is that clear, guys? Okay? So these kind of movements, can be achieved. If at all, if you don't have a welder, nothing to worry. If you get a good torque, make sure within 72 hours that you are actually giving at least a temporary processes, if not a permanent processes. If you don't have time for a permanent processes, at least give temporary processes. Don't give individual crowns and all. It's all one unit, because that permanent processes itself will serve as a splint. So what exactly you're doing? You're actually splinting all the abutments together as one unit. So the permanent process also will serve as a permanent splint, which will prevent, it will save a lot of time to you if you do sin crystallization or welding basically. Okay. So and obviously it will reduce the mechanical stress, minimum working time, in the patient mouth, and maximum safety. Okay. And in little bit more details about synchronization will be dealt in the prosthetic part also. Now this is how it looks once you actually, if you see all the abutments, if you see here, all the abutments are actually, welded together. Now all the abutments will act as one single unit. Right? Now this is a clinical photograph where all the, abutments are actually welded together. Now don't worry about the direction of the pterygoid implants. Don't worry about the direction of the pterygoid implants. I hope in the last session itself I have explained to you, whenever you are placing a pterygoid implants, the direction of the drill, I think I hope I have explained to you. But anyways, I'll just briefly tell, about it, because some people might have forgotten also. Don't worry about the direction of the pterygoid implants, that, they are actually placed like this. Rather than in a vertical direction, they are actually placed at an angle. Because they have to be placed in that angle, don't try to bend them also. Because the pterygoid implants are actually placed for two reasons. One is to finish the supporting polygon one, and secondly, they are actually going to give you a lateral support rather than a vertical support. They are not going to give a vertical support. They are actually for an axial support. So whenever you actually want to place a pterygoid implant in the tuberosity region, just penetrate the gingiva first in a perpendicular direction, as already told, like any other implant. You have to first penetrate in a perpendicular direction like this, right? And since the pterygoid is actually attached at a slightly in a superior direction when compared with the tuberosity, so approximately 35 to 45 degrees of angulation you have to, tilt your drill in a 35 to, now this is perpendicular, 35 to 45 degree of angulation you have to bend, and then slightly buckle, 5 to 10 degrees buckle, and then just go straight. You will be going in the tuberopterygoid region. So don't worry about this. Now let us say this implant is placed like this, intraoral it is like this. Don't try to bend it in a vertical direction like this. No need. You just keep it like this, weld them with the other abutments, because only a metal, covering will be over this. There won't be any kind of tooth. Don't try to do a heroic attempt of putting a third molar also. Not required. We'll be just placing only up to the second molar region. Is that clear, guys? So what are the, coming to the last part, because this is a little shorter session today. Now, what are the advantages of the basal implants is, it saves a lot of your, expenses, obviously, because basal implants are comparably, but if you ask me, it's a little cheaper when you compare with the conventional implants. See, but if you ask me, it is more or less the same, because if I am actually going to place a full mouth, there if I do 6 implants, I am going to put 10 implants here. Right or wrong? So for each tooth loss, I am going to put 2 implants instead of 1 implant. So the cost will be almost the same, right? But it will save, definitely it will save a lot of time. It will definitely save you a lot of time, because, obviously, for known reasons that within 72 hours, since you have to rehabilitate the case, right, the patient is going to return back to the function very soon. It saves a lot of time. See, if not today, probably in another year, a lot of time. And obviously, in cases of conventional implants, the most commonest problem that will happen is the abutment loosening, because it is held in place with a small screw. But in cases of basal or single piece implants, the abutment comes along with the implant. There is nothing like a screw loosening here. There is no screw loosening that will happen here. Clear, guys? And obviously you can load it immediately or within 72 hours. This is one of the major advantages. And flapless technique. Again, please practice flapless technique, that too without any kind of surgical stents. Don't require all these sophisticated things. You can straight away practice that. Nothing is going to happen. Okay? And obviously, see, as I said, it will be very difficult, for the people who are actually hardcore conventional implant practitioners, 2-piece implant practitioners like me. Even it was not easy for me to, first of all, digest the fact about the basal implants. Though I have done so many implants by now, initially it was very, very difficult for me to actually accept the principles itself. It will take some time. But my humble request is, it be open-minded, have an open mind, so that approach it with the patient in your mind. Approach with the thought of the patient in your mind, how well you can rehabilitate the case. Right? So with these in mind, and for beginners who actually don't practice any kind of an implant, I'm sorry to say, but you will be more successful. I'm not demeaning anybody here, but because you don't have any confusion in your mind, the beginners will not have any kind of confusion in their mind, whether to accept this method or that method or this method or that method. No. If you see, any implant will be successful if you actually apply the principles properly, be it a conventional or a basal implant. I'm not saying basal implants is easy definitely to do, because you require only a single drill. You don't require multiple drills also. One drill put in a proper direction, you can actually put the implant in a proper direction. It's once and for all, it is done. So for a beginner, it is an clear, guys. So coming to the complications, I think this is the last part of. So it is advisable that you give a test dose of local anesthesia to almost all your patients if they don't have any kind of anesthetic exposure prior. They are coming for a dental treatment first. An anaphylaxis. The most common, first initial reaction you will get what? Even the trigeminal act as a wedge, as a block there, so nothing is going to happen. If you get a 2 to 3 drops of blood also, nothing is going to happen. Just put a small cotton plug there, just stop it for a while and then the bleeding will be arrested. Same in the case of ANS also. So these are the complications that you might encounter in cases of maxilla. And in cases of mandible, the only complication is in the anterior most region. In the interforamen region, when you are actually placing the implants, you have to place it more in a labial angulation, more of in a labial angulation, in a labial angulation like this, or in a straight, but never lingual angulation. Don't do it in a lingual angulation, because I told you when I was dealing with the surgical aspect itself, if you are going in the anteriormost part, you might actually damage the lingual artery, and I told you how to do it, how to ligate it and all. I explained to you in the module 2. Who did not attend that, please go back to the module 2. It is, I think, available online, so you can actually go through that module. I explained actually there how to do that. Okay, ligation. And now you might have a paresthesia if you are actually involving the inferior nerve. If you for sure, if you know that you are involving the nerve, if you actually follow the angulation what I explained to you, 5 to 10 degrees slightly in a lingual angulation, if you just go straight, you're not going to damage any kind of nerve. Okay, most common is a paresthesia. If you have a paresthesia, don't worry, it is only temporary, because you would have just touched it also. I'm not saying you would have damaged the nerve. Even if you touch it also, sometimes a paresthesia will come, and that paresthesia will stay for 2 to 6 months, depending on the patient's healing capacity, because it depends upon each individual. So reassure the patient. You can always give them a tablet called Renerve. Okay, so you can give a Renerve tablet and then some mild steroid for a couple of days, and then that will actually subside any inflammation there in the nerve area. And these are the complications that you might actually happen in the mandible. Okay, so with this, I finished the surgical module, and the next module will be, actually we thought of telling about the hands-on for this, but we thought, first you should know the prosthetic aspects, because the bending, trimming and all is involved there. So it makes it more sensible if I give you a demo on the models after the prosthetic the sessions. So from the next session onwards, we'll let you know the date and time that will be taken by Dr. Rajesh Aduri. So in these 3 modules, I hope I have covered to the maximum extent that is required for the basal implant practice. If you still have any questions, please post it in the group, so that we'll be able to answer all your questions. And I hope, guys, that I have given enough information. And if you would like to enroll yourself for a hands-on course, you are most welcome, so that if you still have any few questions, or few doubts, or that small block that is there for you to start the basal implants practice, that will be removed once you actually attend the hands-on